So I'm going to speak today about some of the pharmacological interventions, so the medication side of intervening for some of the mental health, non-motor sort of symptoms that come along with Parkinson's disease. Like any good talk, I guess, we start off with some of the goals. First, as has been stressed by some of the other speakers today, I want you to appreciate the range and prevalence of the neuropsychiatric symptoms, and that's a term that I sort of use, neuropsychiatric, same as psychologic, whatever you'd like to choose, symptoms experienced in Parkinson's disease, and really reiterating that simply to stress how common they really are and how important it is to recognize them. Understand how Parkinson's disease and some of its treatment may lead to these types of symptoms, why they might occur. Review some of the interventions we use, the pharmacological interventions we use to treat them, and then highlight some of the differences in these symptoms versus what someone in a typical psychiatric practice might see, how the phenomenology of mental health troubles are different in Parkinson's disease, and some of the treatments are different in Parkinson's disease. Objectives are just sort of what I'd like you to be able to do by the end, and again, reporting the prevalence of these various neuropsychiatric symptoms, listing the ones that are seen in Parkinson's disease and how they're different from non-Parkinson's, know some of the specific pharmacological treatments for depression, anxiety, psychosis, and dementia in Parkinson's disease, and then explain why some of the treatments should not be used in Parkinson's. So to start off, I think sort of going back to the beginning, to James Parkinson, who first described what he called the shaking palsy at the time. This was 1817, London. He was actually an apothecary surgeon. He wasn't a physician, and there was a difference back then. So sort of a pharmacist who did surgery. He described 7 cases, 3 of whom he examined himself. One who he just saw actually walking down the street and observed very astutely and described, and 3 that were described by other physicians or other people. But what he described was an involuntary tremulous motion with lessened muscular power, in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured. And I'm going to sort of break this down a little bit to get started. So that's where Parkinson lived and practiced in London. I spent some time there. It's actually a martini bar at this point in time. Not the pharmacology we're going to be talking about today, but just thought it was funny to see. So what did he describe? He described the resting tremor, bradykinesia, or slowed movements, muscle rigidity, and so those 3 are sort of thought of as the classic motor triad that we diagnose Parkinson's disease by. A shuffling gait, and stooped posture. So what did he sort of not appreciate at that time, I guess, is what I'm gonna focus on today. So he mentioned the senses and intellect being uninjured. He didn't fully appreciate the psychological or neuropsychiatric symptoms that we're talking about today. He did actually, in the full essay, briefly mention melancholy or sort of a lack of emotion, but definitely didn't capture the range of neuropsychiatric symptoms. And so in recent years, these psychological symptoms have been increasingly recognized as manifestations of PD. And some, I would say recognized very recently as part and parcel of the illness itself, not just sort of side symptoms that we see. And it's been described recently, this is a 2011 paper in Movement Disorders by Dan Weintraub, who's a big psychiatrist in the field of Parkinson's disease, and Byrne, describing Parkinson's as the quintessential neuropsychiatric disorder. So sort of stressing that the psychiatric is as important as the neuro parts of this illness. Depression, anxiety, psychosis, apathy, impulse control disorders, cognitive impairment and dementia, and disorders of sleep and wakefulness. Really the full range of psychological symptoms that one can experience or that you see in Parkinson's disease. And this is what sort of drew me to seeing Parkinson's patients during residency. We had a specialty unit where we would see these kinds of patients in psychiatry and realizing that they had all of these symptoms. And I think that a lot over time can probably be learned about other psychiatric disorders based on what we see in Parkinson's disease as well. This is from that same paper, and it's just a graph to demonstrate this is the number of publications about these various neuropsychiatric symptoms that have occurred since 1986, 1990, up to now. And you can see there's almost an exponential increase in the number of papers published looking at cognition, depression, those two sort of being the biggest areas, but also impulse control disorders, psychosis, all of the things that I just spoke to. So I want to take a second to sort of talk about not only that these symptoms occur in Parkinson's disease, but why they might occur and what things we do to treat Parkinson's patients that might actually cause some of these symptoms. So the basal ganglia, which are exactly as they sound, they're sort of groups of neurons at the base of the brain that are highly involved in the movement side of Parkinson's disease, the movement disorder itself. But when they're functioning normally, they're involved in the automatic execution of learned motor plans. So they allow you to sort of move fluidly and slowly, or fluidly and appropriately. And they're implicated in action selection, and I'll talk a little bit more about that. So you can imagine if they weren't functioning properly, if the basal ganglia circuits weren't functioning properly, you would have slowed down movements. It wouldn't be as automatic. Action selection, if that was slowed down, you might see things like coming to a doorway and freezing and not fluidly being able to pick the right movements to get through that doorway. So allowing for the initiation, termination, and scaling of movement. And they require dopamine from the substantia nigra to do all this. Dopamine plays a big role, and that's some of the pharmacology that I'll get into in a minute. So this is just probably a review for many of us, but the basal ganglia consist of the caudate and putamen, which make up the striatum, the globus pallidus, and the nucleus accumbens is a part you don't hear about in terms of the motor circuits as much, but plays into some of the emotional and cognitive aspects that I'll talk about. And this is just a little model of sort of where they sit in the brain. So I want to go through briefly. So here's an example of dopamine in normal movement. So you're getting dopamine from the substantia nigra of the brain that goes into the striatum, the caudate and putamen. And this is just sort of a normal outflow of dopamine into the striatal neuron. And because of this, we have sort of normal fluid movement. So this is a patient without Parkinson's, or a person without Parkinson's that's functioning normally. In Parkinson's disease, we have a decrease. So these, because of the pathology of Parkinson's disease, the dopamine neurons in the substantia nigra have essentially died off, and you don't have as much of this dopamine to hit the striatal neurons. And because of this is when you start to see the symptoms. And it was mentioned in an earlier talk, but it's pretty far into the disease course, actually, that you start to see the movement problems, when about 80% of these neurons have bit the dust, so to speak, so that you don't have enough dopamine to move fluidly, and you start to see the motor manifestations. And then just to show treatment with some of the dopaminergic medications, specifically levodopa treatment, this is sort of an example. You have less of the natural dopamine in the brain, and the normal dopamine in the brain has sort of a tonic effect. There's always some level of it there, so it's tonic. So then you start to hit these same neurons with big phase waves of dopamine, essentially, of levodopa. And it's that sort of phasic stimulation of the receptors that we think plays into a lot of things like the dyskinesias that are seen later in the illness. So when you have these phasic pulses of dopamine, as happens with levodopa, over time, those postsynaptic receptors become sort of hypersensitized. They're almost looking for dopamine. And so when they do get hit, you get sort of overactivity, and you get these things like dyskinesias, which have been touched upon a little bit. So why would any of this be important to mental health professionals or psychiatrists, psychologists, social workers? And this is essentially why. So this is on the left-hand side, you can look, that's the motor circuit. So the basal ganglia, cortex, so cortico-striatal, palato-thalamo-cortical loops, all the areas that are involved in that motor loop that get the dopamine from the substantia nigra. So that's on the left. Well, it turns out these same circuits, although slightly different areas in each part of the brain, are also involved in the associative or cognitive areas, as well as a limbic circuit, so emotion as well. So you have the same parts of the brain and the same types of circuits that are involved in all of these different areas. And it might be beyond what we need to get into right now, but you almost see some of the same type of phenomena that you see with motor trouble, sort of that scaling, initiation, termination. You can think of those things happening in the cortical areas, or in the cognitive areas, as well as the emotional areas as well. And this slide speaks to that a little bit. So I focus on dopamine. Other neurotransmitters are involved. This is a bit simplified, but so looking at low dopamine on the one side, as you would see in Parkinson's disease, and high dopamine, as you might see when you give someone levodopa or dopamine agonists. And you have the motor symptoms, so with low dopamine, bradykinesia, a motor component of apathy. And when you have excess dopamine, you have dyskinesia and motor impulsivity. In terms of the cognitive effects that we see with low dopamine, you see some of the things that have been described. Bradiphrenia, or slowed thinking, cloudy thinking it was called earlier, I believe. Sort of an empty brain syndrome, the extreme of that, and the cognitive component of apathy. And then with high dopamine, you're going to see some of the impulsivity, flight of ideas, and novelty seeking. And then likewise with the emotional or limbic areas of the brain and the effects we get from that. Low dopamine, you can see depression, apathy, anhedonia, anxiety and harm avoidance, and drug withdrawal syndromes. And on the other side is sort of the fun stuff, the hedonism, euphoria, the mania, emotional impulsivity, behavioral addictions, or these are sort of related to these impulse control disorders, and increased risk-taking behaviors, and then, of course, psychosis as well. So I'm going to go through a number of these neuropsychiatric symptoms, specifically depression, anxiety, psychosis, talk a bit about impulse control disorders, and then talk a bit about dementia as well. Each of these, I must say, could be its own talk, so we're going to sort of do a primer in each area. And again, later on, we'll have some time for questions if you have specific questions. So depression, as has been mentioned, present in up to about 50% of patients with Parkinson's disease. And part of the issue is related to the fact that there is such overlap between depression symptoms and some of the symptoms of Parkinson's, as has been mentioned. But another issue is that we think of depression in psychiatric clinics typically as sort of this major depression, very, very marked depression, where there's a fair number of patients with Parkinson's who have more minor forms of depression. But the issue being that they're often not recognized and go on to progress to become major depression in the long run. So it's under-recognized and under-treated. They say about a third of patients who have depression and Parkinson's disease is actually recognized and treated. Poor functioning and quality of life are associated with depression, greatly increases difficulty for caregivers, and this may come on as part of sort of a prodromal phase of Parkinson's disease related to the progression of the pathology in the brain. So things like depression and anxiety we're finding may come on 5-10 years before the motor symptoms come on. For review, so going through the symptoms of depression: depressed mood, loss of interest or pleasure, change in appetite, weight, sleep problems, fatigue, feelings of guilt or worthlessness, psychomotor slowing, poor concentration, thoughts of death and suicide. And in blue, I just highlighted some of the potentially overlapping symptoms of depression and Parkinson's disease that can make it difficult to recognize. There are psychological factors that come along with a chronic illness, such as Parkinson's. So sadness, helplessness, and hopelessness may stem from having a chronic illness. Isolation because of the disability or embarrassment of the symptoms. decreased quality of life, and increased stress in relationships often occurs. But I want to stress that it's not a normal reaction to be depressed because you have Parkinson's disease. There's a certain degree of normal reaction to the disability, but that doesn't mean that we should just chalk up depression to, oh, someone has Parkinson's disease, so it's expected, because that's not the case. And then there's the biological factors. So many of them are similar to biological factors that are present in non-Parkinson's populations for depression. Genetics or family history, there's actually a female preponderance of depression in Parkinson's as well as in non-PD populations. Brain changes in the neurotransmitter system, so not just dopamine, but serotonin, norepinephrine. Also, they change in both Parkinson's and in depression. And some patients experience what's sometimes termed off-period dysphoria. So you have these off-medication periods, and they have sort of a dysphoric emotion associated with that. And I'll talk a little bit more about that as it pertains to anxiety as well. So biological or medication depression treatments. I just sort of go through a number of the different things that may be used. Probably the most commonly used and most well-known nowadays are the selective serotonin reuptake inhibitors. But there's also serotonin, norepinephrine reuptake inhibitors as antidepressants. Some of the older antidepressants, tricyclics and monoamine oxidase inhibitors. Dopamine agonists, which are used to treat the motor symptoms, but I'll also talk about them in terms of treating depression. And then ECT, or electroconvulsive therapy, and transcranial magnetic stimulation are also options that are out there. So name that medication. I just for the sake of review, put some of the most common medications in each of these categories for the sake of recognition. I don't know that I need to read through them all, but so selective serotonin reuptake inhibitors probably the most common that you'd recognize. Things like fluoxetine, sertraline, paroxetine, citalopram, escitalopram, and fluvoxamine. I use generic names for all of these, so Prozac, Zoloft, Paxil, Celexa, Lexapro, Luvox for the first ones. And again, so those are there, and I won't read through all of them, but those are the same classes that I just talked about. So as of 2011, the Movement Disorder Society's recommendations for what was actually efficacious for treating depression and Parkinson's disease was pretty sparse. So pramipexole, which isn't even typically thought of as a first-line antidepressant, is a dopamine agonist used to treat the motor symptoms, was found to improve depression scores. And that may have something to do with actually addressing that off-period dysphoria as well in some cases. So nortriptyline and desipramine, which are both tricyclic antidepressants, an older class, were both thought to be efficacious. But the SSRIs, the more recent medications, really didn't have a lot of good evidence in trials that were out there. Since then, since 2011, there have been a couple trials that have shown SSRIs to be more promising. So this is a big study that came out in 2012 in neurology. 16 weeks, people were randomized to placebo, paroxetine, and venlafaxine. Venlafaxine is a serotonin norepinephrine reuptake inhibitor. And the change in the HAM-D score, which is the Hamilton Depression Scale, one of the scales frequently used in research, there was a significantly greater improvement in scores in the paroxetine and venlafaxine groups compared to placebo. And the remission rate, so getting the scores down to the point where you could say this person's not really necessarily depressed anymore, were significantly higher in the medication groups. Although if you look at the percentages, 36%, 32%, 28%, it's not a huge percentage higher. So just some more evidence for using SSRIs. I'm going to talk a little bit, because these are the most commonly used medications in treating depression generally and in Parkinson's disease, I'm going to talk a little bit about actually selecting one of these, so some of the practical guidelines for selecting some of these medications. So SSRIs, although they're very commonly used, have a number of side effects that can be significant in Parkinson's disease. Nausea, low appetite and weight loss, headache, insomnia, anxiety, sedation, Worsening tremor is one area that for a while it was thought that these actually worsen the tremor in Parkinson's disease. More recently, there's been a couple of studies that have not shown that, but it's still a question. Worsened sexual dysfunction, low sodium, and bleeding issues. So you can see that some of those side effects are the same things we've talked about Parkinson's patients experiencing in the first place. Sexual dysfunction might be low appetite or weight loss, anxiety, sleep troubles. So, there's potential to worsen some of those with the side effects. I'm not sure how many of you prescribe something like citalopram, but there's been a big change. This was one that we often used a year plus ago in older patients up to doses of 60 to 80 milligrams until the FDA came out with a warning saying that it prolongs the QT interval in heart rhythm. So there's potential for cardiac arrhythmias using doses above 20 milligrams in patients over 60 years old, which is a large number of Parkinson's patients. And then some of the SSRIs, paroxetine and fluoxetine, so Paxil and Prozac, have high interactions in the cytochrome P450 system. So there's potential drug interactions, and as we know, talking about comorbidities, a number of Parkinson's patients have a number of medical comorbidities and are on multiple medications, so this can be a problem. In terms of selecting an antidepressant, some things, trying to optimize which medication you use for a particular patient. We've covered a little bit that Parkinson's can be a very individualized illness, can look very different from patient to patient. And so in choosing an antidepressant, that should be taken into consideration. So from activating to sort of least activating or sedating, you have bupropion, fluoxetine, sertraline going sort of one way or the other on the activating end, and going down to medications like mirtazapine or the tricyclic antidepressants or trazodone, which can be quite sedating and often are even used for that purpose, the purpose of helping someone get a good night's sleep. In the case of trazodone, which is a medication that came out as an antidepressant some years ago, and the doses that you needed to get to, 400 or 500 milligrams, were helpful for depression, but the person also slept all day, so it didn't really do the but. So we use it in lower doses often now for sleep. Weight gain, again, can be something that in Parkinson's at times is a desired effect. If there's decreased appetite, if you have patients who have dyskinesias, things like that, patients can actually lose a fair amount of weight because of the motor activity, the constant motor activity that they're experiencing throughout the day because they're burning calories while doing that. So bupropion is one that tends to be weight neutral or cause some weight loss. And that's in a class by itself. It's sort of its own version of antidepressant. I'll touch on that a little bit more in a bit. And then you have at the far end the weight gain, so tricyclic antidepressants and mirtazapine. And this has to do with working on the histaminergic receptors in the brain and the gut, actually. But mirtazapine is something that I'll say I often use in Parkinson's patients and in geriatric patients in general because its side effects of sedation or helping with sleep and appetite stimulation are often desired. And it tends to be otherwise one of the more gentle medications, I think. So moving on to anxiety, again, the prevalence around 40%, so very common. Men and women tend to be affected equally in Parkinson's disease anxiety. Can present as any of the range of anxiety disorders, as Dr. Ellen spoke to. Maybe directly, again, related to changes in motor symptoms or off periods. So you get patients who, once they have this off period, they start freezing, they can't move, they get very anxious. The gentleman we saw earlier who couldn't walk through the doorway may get very anxious trying to do that in cases like that. But you also get an anticipatory anxiety, as often comes with things like panic attacks or anxiety. So not just that off period, but that fear of having that off period becomes a problem, and the anxiety sort of grows from there. And this may also, some studies or people indicate up to about 20 years before. We found out there's brain changes 10, 20 years before the motor symptoms. You may start to see anxiety symptoms. And there is some work in trying to identify people based on some of these symptoms, along with things like loss of smell and REM sleep behavior disorder, to look at sort of biomarkers or things we can use to predict whether someone will have Parkinson's disease. Although I don't think there's any definitive profile that's around yet. Just to list them, again, the symptoms of generalized anxiety, but again, stressing that worrying about one's physical condition is a natural reaction to some degree in Parkinson's, but debilitating excessive anxiety that's distressing and causing loss of function is not normal. It should not be accepted as normal. Panic attacks, all of the physiologic symptoms of panic, and these can be related, as I just mentioned, to the off periods. And then the anxiety treatments, essentially the same as the antidepressants, and this is the case in Parkinson's and not, with the exception of bupropion, which tends to be it's a more activating antidepressant and often can worsen anxiety. So not typically used as a first line in a patient whose main issue is anxiety. In Parkinson's patients, the old sort of adage to start low and go slow. Patients may initially experience an increase in anxiety with starting antidepressants, or an increase in agitation or insomnia. It's thought in general that higher doses are often needed to treat anxiety than to treat depression, which can be problematic getting to those doses in older patients or Parkinson's patients. However, you often see that Parkinson's patients or geriatric patients are treated with very low doses of antidepressants without increasing the dose very much. And often they need to actually get to some of those higher doses that you would use in any patients to really treat the symptoms. The problem is they're more prone to the adverse effects for various reasons, so it can be tough. But, so sertraline is a medication that you can start as low as 25 milligrams and go up to 200 milligrams as a maximum dose to treat depression. Well, often you see a Parkinson's patient or a geriatric patient put on sort of 25 milligrams and then they just stay there and it's not working. They say it's not working without sort of increasing the dose. So often that's where the importance of having specialists involved, that's one of the roles that I play working in the movement disorders clinic, is that I feel more comfortable, increasing the doses, really using these medications where other people may just be starting them. And then there's this sort of what I call now medications, the treatments for anxiety in the moment if someone's having a panic attack or something like that. The benzodiazepines, so clonazepam, lorazepam, alprazolam, but these have pretty significant issues in older patients, geriatric patients. The risk of falls increases. There's abuse potential there as tolerance builds to the medications. And often if you work on an inpatient medicine unit or something, you get a patient who comes in delirious, very confused. These medications can be big culprits for that. As well as the anticholinergics, which are used to help treat the motor symptoms as well, but things as simple as Benadryl, so people take an over-the-counter Benadryl to sleep or for anxiety, not thinking it could do much harm, but some of the same troubles with these medications. So very big culprits for delirium and confusion, and then things like urinary retention and constipation can be major issues for a patient with Parkinson's who has autonomic dysfunction to begin with. So psychosis I'm going to talk about in a little bit more detail. This is an area that I'm particularly interested in. And we heard a bit earlier about the typical characteristics. So you have hallucinations, delusions. What we found is there's also what are being called minor psychotic symptoms in Parkinson's disease, things that aren't usually talked about in terms of schizophrenia or other psychotic disorders. So the three main ones that are often asked about and looked at are sense of presence, and I'll talk more about what these are, illusions, and passage hallucinations. And prevalence of psychosis when looking at these other symptoms can be as high as 60%, typically range from about 20 to up to 60%. A lot of the earlier studies looked specifically just at visual hallucinations and didn't take into consideration some of these other things, including delusions. So prevalence rates can be quite high. So hallucination, so it's a perception in any of the five sensory modalities without an actual stimulus being there, seeing things that aren't there, hearing voices when there's nobody speaking to you. Visual hallucinations are by far the most common in Parkinson's. Typical visual hallucination is a complex visual image. So often, as was spoken about earlier, they will start off as sort of non-threatening, seeing children or a loved one who passed away, something like that. And it's not very bothersome to the patient. The problem is what has been shown as sort of there's cognitive decline, and over time, the benign hallucinations, benign symptoms are no longer benign and they start to advance. Abilities can be affected, and as I said, I use the term insight. Initially, they tend to have insight, but this can be lost over time. So these minor symptoms, so things like an illusion is a distortion of a distortion in the perception of a stimulus that is actually there. So looking at a table and it looks like something, an animal to you. Sense of presence is something that maybe, everybody's experienced at some point. It's a feeling that someone's sort of in the room with you or watching you, but you look around and there's actually no one there. And then passage hallucinations are that sort of seeing shadows or figures or things out of the corner of your eye, and you look and there's nothing actually there. And these seem to be sort of precursors that then progress on. But the idea being if we can screen early maybe for some of these things, we may be able to address the psychosis earlier and possibly change the course. This is just a study that I had worked on in residency, one of my first forays into Parkinson's disease, looking at the prevalence of these different phenomena. We found that 26% of patients were experiencing any of them at any one time, and by far the most common were these minor psychotic phenomena, so the sense of presence, the passage hallucinations and illusions. Visual hallucinations being the most common of the hallucinations, but also finding a fair number of patients who experience auditory, olfactory, or tactile hallucinations, and then delusions in 3% of the population. Dr. Allen spoke to the different types of delusions that might be present. You can imagine how problematic it would be if a patient starts thinking their primary caregiver is cheating on them with the mailman or stealing from them or things like that, the type of dynamic in the home that could cause. So risk factors: older age, longer duration of disease, cognitive impairment, sleep disturbance. So there tends to be, we think, some sort of a continuum with the REM sleep behavior disorder, almost as if some of the hallucinations they're having are REM intrusions during the day, sort of like a dreamlike state during the day, depressed mood, and vision problems. So it was talked about how there's less color differentiation in Parkinson's disease, which might make it more difficult to, say, look at a table or something and recognize it as it actually is versus seeing it as something else. But psychosis is associated with increased caregiver burden, nursing home placement, and mortality in Parkinson's patients. This is just a graphic related to the etiology of psychosis. So you have genetics, visual dysfunction, brainstem and sleep dysfunction, cortical pathology, Parkinson's medications, possibly deep brain stimulation, all leading to combined Parkinson's psychosis. So often throwing those Parkinson's medications is sort of in there, sort of the fuel for the fire. And I'll touch on that in just a second. So first line treatment for Parkinson's psychosis is to look at their current medication regimen. Actually, first thing is to look to make sure that there's nothing medically going on that might be causing a delirium or sort of alterations in consciousness, things like infections, other drugs or medications that might be playing into things. And once that's ruled out, looking at their Parkinson's medications. And there's not studies showing this, but this is sort of expert consensus on how to taper or what things to get rid of first and in what order. So anticholinergics, as I mentioned, things like Benadryl can cause delirium and lead to hallucinations. Next would be amantadine and selegiline. And the dopamine agonists seem to be major culprits for this. Next would be the COMT inhibitors. So the COMT inhibitors would be next in line, and those are they prevent the breakdown of levodopa or these dopaminergic medications and keep them around longer. And often you end up managing the patient just with levodopa so that you can sort of alter the dose and work with that as much as possible and get them down to the lowest dose, which might treat their motor symptoms as well as help with some of the psychotic symptoms. This is a graphic taken from an article about how antipsychotics work. And so briefly, I'll go on a tangent about, so dopamine, what dopamine really does for us working normally is it tells us what's salient or important in our environment around us. And that's how it works for all of us on a daily basis. What happens in psychosis, so for example in something like schizophrenia, is you have a dysregulation in this dopamine system and you have sort of an increase in the dopaminergic output in the neurons of the brain and those same circuits that I showed earlier. And what this leads to is what's sometimes termed aberrant salience. So things that wouldn't normally be important to us in our environment start to become important. And again, this is talking about something like schizophrenia. And so if you can imagine if a 20-year-old guy started thinking, well, that person seems like they're talking about me over there, and the TV seems to be giving me messages, then things start to seem important in their environment that aren't necessarily, they start to come up with essentially delusions and ideas to explain that importance away. And that's how delusions start to develop, or that's how they're thought to start to develop. What happens with antipsychotics is you block the dopamine, and over time, that aberrant salience starts to sort of calm down a little bit. And for the psychiatrists in the room or people who work with, say, schizophrenia, adherence is a major issue, so they stop the medication, and over a little bit of time, that salience comes back and the delusions come back. Essentially, what's happening in Parkinson's disease is we're feeding patients the dopamine that can lead to that aberrant salience occurring in the environment. So, something out of the corner of your eye that you might not notice typically, all of a sudden they're seeing things out of the corner of their eye, having hallucinations, starting to have delusions, and we're doing that iatrogenically in some ways to treat their motor symptoms as well. So the problem is, what do we do about this once it starts to occur? And there's this balance between the motor symptom control in Parkinson's and treating psychosis. So the same medications we need to treat the motor problems are the ones that cause psychosis, and so we have to find that balance. Again, just listing sort of some of the names of the more recent atypical antipsychotics, which are thought to have less motor trouble associated with them. So we're really a hope because for treatment of all psychotic illness, as well as in Parkinson's disease. And then the older typical antipsychotics, which are notorious for causing motor problems and increased problems in Parkinson's disease, things like Haldol, people may most likely have heard of. But what's been shown is that most of even the newer antipsychotics work at those same receptors that cause motor problems. So things like risperidone and olanzapine in studies have been shown to reduce psychotic symptoms and have some efficacy there, but they also cause significant deterioration in the motor function, essentially to the point that it's not worth it to use them to treat the psychosis. The two that have been shown, the two that are most commonly used are clozapine or Clozaril and quetiapine or Seroquel. The reason being they have a different receptor profile, are much less likely to cause these motor symptoms. The issues are they're not exactly always easy to use. So quetiapine, despite having this good side effect profile in Parkinson's disease, actually hasn't in studies been shown to be very efficacious. So it's been no difference between placebo in about 4 studies, and equivalent to clozapine in 1 study, but that didn't really have a good placebo arm. So not good evidence per research to use quetiapine, although that's what will be first line if you go into clinics that you find people using, because it's easiest to use. Now clozapine, on the other hand, has a lot of evidence for efficacy in treating the psychosis, treating the delusions and hallucinations. However, it requires weekly blood draws due to risk of agranulocytosis or a drop in the white blood cell count. And so there's a lot of logistical issues with using it, and it can be very difficult, if adherence and things like that can be difficult in the first place, and have somebody need to come in for weekly blood draws, or they have to sort of start all over, can be very tough. What I frequently end up trying, at least as a first line, are the cholinesterase inhibitors, some of the dementia medications, because these have been shown to have some efficacy in dementia with Lewy bodies especially, but rivastigmine in Parkinson's disease psychosis has been shown to have some efficacy as well. And these tend to have sort of a gentler side effect profile, not as risky to exacerbate their motor symptoms. So I want to move on and touch upon the impulse control disorders or impulse control behaviors that we've spoken about a little bit already. So an impulse control disorder is a failure to resist an impulse, drive, or temptation to perform an act that is harmful to the person or others. That's sort of the DSM-4 definition of it. They're being increasingly recognized as a problem in Parkinson's disease, and this, I would say, is actually sort of the hot area of research, or one of the hot areas that's being looked at currently. It's related to the dopaminergic medications used to treat Parkinson's disease. So specifically, dopamine agonists are the biggest culprit, although it still doesn't tell us why one patient might experience these type of behaviors and the other wouldn't. You can have two groups of patients, each being treated with the same doses of these dopamine agonists, such as pramipexole or ropinirole, and there's no sort of dose response for sure with these medications. So it's a class problem with the dopamine agonists, but there tends to be, we think, other factors that are playing into it. Has also been reported in some patients following DBS surgery. So some of the main impulse control disorders that are looked at: compulsive shopping, pathological gambling, and compulsive hypersexuality. So you'll have a patient who's never had sexual compulsions or issues with, has been happily married for a number of years, and they get treated with a dopamine agonist, and they're on the internet looking at porn for 12 hours at a time, calling phone sex lines, visiting prostitutes. Again, you can see how, if this is related to the Parkinson's treatment, how that could ravage sort of a marriage or a caregiver relationship. Compulsive eating is another one that's often looked at. So patients who are gaining weight because they're up in the middle of the night, and I've seen patients, who are eating full cakes and things like that. I mean, it's not just sort of snacking in the middle of the night. And punding is another one that's often included. Punding is sort of repetitive, compulsive, but nonsensical behaviors. For example, I had one patient who, for hours, would be up all night. A woman who used to sew, who had a lot of buttons, and would just put them in order, for hours and hours on end, with no real purpose to what she was doing. And then there's a subgroup of these patients who have what would be called levodopa dependence, or sort of compulsively using their dopaminergic medications, and sometimes driving these behaviors, and it's almost as if they're addicted to the levodopa or their dopaminergic medications. So the prevalence of any impulse control disorder, 13.6% in Parkinson's disease, which is a fair number of people, and I gave the breakdown of some of the different types I just talked about. 5% gambling, 3.5% compulsive sexual behavior, 5.7% compulsive buying, 4.3% binge eating, and then often they have more than one type of these disorders. And so this is where, I did some research on impulse control disorders and went out and saw patients in their homes, a number of patients to talk about ICD specifically. And when you hear some of the stories, it really hits home at how devastating some of this stuff can be for families. This is just one sort of caregiver perspective. So it's a wife of one of the patients who said he'd never overeaten, gambled, or sought out pornography or been unfaithful until he started pramipexole. So he started this medication, and very much in line temporally with that, she says, our marriage has crumbled, family life has been destroyed, and our children are in therapy, and so are we. taken away his ATM and credit cards multiple times. The last time was earlier this week because he was unable to tell me what happened to all the money. And I'm talking like tens of thousands of dollars, at times $100,000. And he will not stop he will now stop taking it. There's no question that he functions better physically with it than any other drug. So this is actually an issue and a phenomena that's not totally clear as to why, but the medication that tends to cause an impulse control disorder in many patients is also the one that gives them by far the best motor control of their motor symptoms. So you really run into this conundrum of what step to take next. Number of associated characteristics. So I mentioned dopamine agonists, but there seem to be other characteristics that are associated with the impulse control disorder, including younger age of Parkinson's onset, being unmarried, family history of gambling or alcohol problems, and a novelty-seeking personality. So some of those make sense. Tends to be a male preponderance with certain things, hypersexuality and gambling, which I guess some people would say makes sense as well. And higher levels of depressive anxiety and obsessive compulsive symptoms are associated with them. The trouble with impulse control disorders is that other than taking away their dopaminergic medications, there's so far not really any good treatments that we found. There's one study on amantadine that has shown it to be helpful in a small sample of patients. However, amantadine has also been associated a number of times with impulse control disorders. Deep brain stimulation has been thought of as one potential intervention, although I've seen a number of patients who their impulse control disorder continued once they had deep brain stimulation. And also DBS has been shown to bring on cases of ICDs in a few instances. Going back to the psychological intervention talk, I was just involved in a study that was just published last month in Neurology showing a CBT intervention for impulse control disorders, which did have some efficacy. Not so much specifically, it did have efficacy in terms of the impulse control disorder behavior, but overall sort of psychopathology in both the patient and the caregiver improves. So depression in the caregiver as well seemed to improve with this intervention. So maybe some promise in the more behavioral aspects of treatment. And the last area I want to talk about briefly, again, this could be a very long talk in itself, but Parkinson's dementia and cognitive impairment, we've talked about it being what some people would call a subcortical dementia. So older terms, people use subcortical versus cortical. A cortical dementia being something like Alzheimer's disease, where you have more of the blatant memory impairment, word finding difficulties, things like that, versus subcortical, where you're affecting these circuits that I showed earlier, where you get a frontal subcortical deficit. Those are things like the executive function, the speed of mental processing, the attention, visuospatial deficits, memory, but memory being more of a retrieval problem. So if you give an Alzheimer's patient 3 words to remember and asking them about it 5 minutes later, they won't remember them. If you give them clues, they still won't remember them. A Parkinson's patient, 5 minutes later, you ask them, they won't be able to recite them for you, but then if you give them clues, such as a category clue or something like that, they can typically retrieve it at that point. So it's more of a retrieval deficit that we see in Parkinson's. And language remains largely intact relative to something like Alzheimer's disease. Important, again, to use a scale that captures the various aspects of cognitive decline. So where I trained, the person who came up with the mini mental state exam was there, so we use that most frequently. But some of the newer scales, such as the MoCA, have more tests that examine the executive function side of things, some of the visuospatial stuff that's going to be more prominent in Parkinson's disease, and so will probably be more telling. You can have a Parkinson's patient often with pretty significant cognitive impairment who can do the MMSE and do quite well still. It won't necessarily capture sometimes their level of impairment. Affects 15 to 40% of Parkinson's patients, but up to 80% over the course of their illness, and 25% of those without dementia will have a milder form of cognitive impairment at any given time. Risk factors are longer duration of disease, males, atypical Parkinsonism, which typically you do see some amount of tremor, so atypical is sort of this rigid akinetic form that's more highly associated with cognitive impairment. Psychosis and apathy are also associated. I do want to talk, I just have a couple minutes left, just touch briefly on Parkinson's dementia versus dementia with Lewy bodies, both of which are actually now grouped under the Lewy body dementias, because Lewy bodies are involved in both of these. It's just sort of the temporal or time course of where the symptoms appear that's different. So it's thought that they may actually be on a continuum of illness. They share many of the same pathological and clinical features. So the time course, Parkinson's dementia is a dementia or cognitive impairment that develops in the setting of a well-established Parkinson's diagnosis, where dementia with Lewy bodies are when the cognitive and motor symptoms occur concurrently or within 1 year of each other. So they're closer together, and often the cognitive impairment can present a little bit earlier. And some of the other problems like visual hallucinations are highly associated with dementia with Lewy bodies and are part and parcel of the initial presentation of the disease. So that 1 year rule is used for research studies looking at the dementia with Lewy bodies. Treatment for dementia and Parkinson's, similar to the SSRIs, all of the medications such as the cholinesterase inhibitors haven't been shown to be as effective in PD dementia as, say, Alzheimer's disease, but rivastigmine does have some studies showing that it's efficacious. And then memantine, which is another dementia medication, has been shown to have insufficient evidence in Parkinson's right now per the Movement Disorder Society, but is efficacious in dementia with Lewy bodies. So, why that difference is not totally clear. Lastly, I just want to touch on DBS and psychiatric disorders, because DBS is very common now, often used to treat things like dyskinesias or off-period dystonias when these problems start to develop later in the disease. May decrease anxiety. My thought on that is, DBS is sort of on all the time, not necessarily in that phasic manner as the dopaminergic medication, so you may not get as much as that off-period anxiety, which can be quite prevalent, so may help anxiety. ICDs and psychosis have both been diminished, but also brought on by DBS, so there's cases going both ways. It has been shown to slightly decrease cognitive function in a number of studies, and some studies have shown that it's in specific domains that this occurs. And typically, the procedure is not performed if there is marked psychiatric illness, if someone's floridly psychotic or has dementia or pretty severe cognitive impairment, they won't go through with a DBS surgery. Very interesting area of research and now starting to be in clinical practice is using deep brain stimulation in those same circuits, as I said, that deal with the motor symptoms of Parkinson's, but also the emotional and cognitive. So using it to treat depression, addiction, obsessive compulsive disorder with actually pretty remarkable results. So possibly, as I said, learning from Parkinson's and taking it to other psychiatric illnesses, this is an area that's promising. And I'd like to thank everybody for attending today.